thanks for coming out. I mean, so many people here to talk about feet. That's impressive. Usually I was telling Marshall before, my foot crowd's usually a couple people, and they just want to complain about their surgery they had 30 years ago. So, and you could complain about that today too, it's fine. But we'll talk about some other things as well. But yeah, thank you guys, I appreciate it. So, a couple of things we'll talk about today. The goal is to basically educate people on what podiatrists are. Believe it or not, people don't know. And we'll talk about some things we do, some common foot conditions, and we'll open up some questions and answers too. And if you have questions, no matter how crazy it might seem, ask. It's fine if you feel uncomfortable. You can always pull me aside and ask me as well, you know, in front of other people too. Okay, so what's a podiatrist? Well, a podiatrist is a foot doctor, right? So it sounds common sense, but if there's one phone call I get more than any other phone calls during the day is a patient calling saying, do you treat this, do you treat that? The common rule of thumb for most of us is if it's on the foot and the ankle, we're gonna treat it. If it's a bone condition, if it's a tendon, ligament, even a dermatological lesion, we treat it. Are there some derm conditions we might refer out to dermatologists? Yes, I mean, they are the authority on a lot of things. But skin conditions of the foot and ankle, we absolutely do treat. So if you're sitting there saying, something in my foot hurts, should I go see an orthopedic, should I go see my primary? No, you can come straight to us. I've seen quite a number of primary doctors mess around with things that they probably didn't need to mess around with, and then ultimately we have to kind of clean up the mess. So foot and ankle related things is all us. Okay. So a little background on podiatry itself. You still do 4 years of undergraduate, but podiatry school itself is separate from regular medical school. We have our own criteria curriculum. First 2 years basically mirror what other people have in medical school, but your last 2 years are strictly lower extremity. So right now I think we're up to maybe 11 or 12 schools in the country. One opened up a couple years ago in Rio Grande, UT Rio Grande. So there's not many as there are in medical schools, but it's very specialized. I myself went to New York College of Podiatric Medicine. For those of you familiar with New York City, it's in Harlem on 125th Street. Not the best neighborhood, but experience you get at these places is incredible. So we tend to not be in the best areas, but we service those communities when we're in school. Afterwards, you're specialized from the start. So unlike a dermatologist or a cardiologist or a nephrologist has to go deeper into things, we are trained foot and ankle right from the get-go after residency. So what is residency for us? Well, like every other medical resident, we spend a few years in a hospital. With podiatry, it's standardized 3 years of residency. In those 3 years, we do all foot and ankle related surgeries and treat patients that come into clinics and things like that, round on patients. If, God forbid, you've ever had to be admitted to the hospital with a foot condition, you may have seen a podiatrist or podiatry resident in the hospital. But they're all basically standardized now. Everybody who treats you would have gone through a rigorous 3-year program. They may not do a lot of surgery on their own, however, they were trained to do surgery during the residency programs. By the way, if I am speaking fast, please let me know. Okay. It's, okay. So real quick background, I'm from New York originally, my wife is a Texan. So I have patients that'll tell me, honey, I need you to go from New York to Texas. And I've learned what that means is just slow down a little bit. So, and it's not me rushing through, it's just a natural tendency. So I apologize in advance, I'll try. But if you catch it again, just yell. Or if you have something to throw me, you can do that too. That's fine. All right, so one of the first things we'll talk about is a term called routine foot care. Now, routine foot care, we'll talk about fungal nails later, but routine foot care is sort of an umbrella terminology that Medicare uses. That covers what we call fungal toenails or calluses. Now, what I tell people is not everybody technically qualifies for that. If you're walking around here, you're 65 years old on Medicare, and you just don't like to clip your toenails, but you can do it, you don't have any other issues, a lot of times Medicare doesn't really like that. They'll say, hey, you can cut your toenails yourself. But if you do have systemic conditions, diabetes, peripheral vascular disease, even some other things we'll talk about later with neuropathy, they do cover it because their preference is, well, you know, if we cut it for you, you won't hurt yourself and potentially land in a hospital and have to be treated later. So the term routine foot care is sort of an umbrella term we use, but encompasses patients coming to the office every couple of months for toenail clipping, callus clipping, things of that nature. So, and also I should say that if you do just have pain from it, some people do have painful toenails, that does get covered as well. And you could say, well, can I just tell the doctor they're painful? I mean, yes, technically you can. But Medicare has become very tricky over the years, and that includes the Advantage plans. They used to be covered broadly for everybody, but they've really cut back a lot today. However, if you're sitting there with the condition of your toenails, you can still see us. The question will be is how often you can come, what frequency, and we'll talk about those things later, okay? So, diabetes and neuropathy is one of the things that qualifies patients, and also circulatory conditions. So diabetes is one of the causes of neuropathy, but not the only cause of neuropathy. Some of you might be sitting here saying, I have neuropathy too, and I don't have diabetes. It could be back-related conditions, it could be substance abuse history, alcohol-related, and even cancer treatments. Certain types of chemo and radiation therapies can cause neuropathic conditions as well. And for those who don't know, neuropathy is essentially degeneration of nerves. So if you've ever felt any kind of tingling, burning sensation in the toes, and that starts to creep up towards your foot, it's hard to sleep at night, that could be the condition that's causing it. So commonly, if you're not diabetic, the next biggest thing I'll usually see are patients with sciatic nerve conditions in the past, sciatica, or hip replacement surgeries where they may have compressed a nerve in the back of the hips, can cause people to have neuropathy as well. I will say there is no cure. Patients always ask, Doc, do you have the cure? I always say if the doctor tells you there's a cure, leave the office because he's about to sell you something that you're not going to want to buy because there is no cure. There are things that will calm it down. There's things that we can do to make it feel less of that burning sensation. However, there are no traditional cures for neuropathy. So I'll put that out there now because I get that question a lot. And I wish I had that cure because I'd probably not be working anymore and living on a golf course and enjoying every minute of my life. But for the rest of us, just know there are no cures, but there are things that can calm it down, they can decrease the symptoms of pain, and we could always go over this if you want to later as well. So, typically, routine care visits are covered every 63 days. Don't ask me why Medicare came up with 63. They said that yours and hers and his toenails all grow at the same pace, which is every 2 months and 63 days. We all know that's not true, but unfortunately, if your nails grow a little bit faster than 63 days, you can't get it covered anytime sooner. So if you qualify, you can only come in over those couple of months. It doesn't mean you can't come in for other conditions, but specifically to have the toenails cut or the calluses trimmed would have to be every 2 months, essentially. So, now, pain relief is the biggest thing. I always tell patients, look, if you're sitting here saying, I don't know if I qualify or I don't know if I should do it, if you're in pain, go get yourself checked out. The general rule of thumb is if there's pain involved, you can be treated and you can get better. So if you've got a painful ingrown nail or your nails are thicker and causing pressure when you walk, these are reasons to get treated, and don't hesitate to come in if you need to be seen, okay? And again, we'll talk about specifically fungal toenails later, but fungal nails do cause patients to have pressure in their shoes and difficulty walking. So these are conditions that can get covered, okay? So what do? Well, you come in and we play with your feet, but we do more than just that. We're gonna check your circulation, we check the nerves, the skin, the joints, the muscles, and all the alignments. We'll talk about some conditions later that are specific, but in a general rule of thumb, if you come in here for just a foot evaluation, we're checking all of these things. When it comes to circulation, as we get older, even the patients that are healthy, regular patients, no history of diabetes, no history of smoking, have circulatory issues. Unfortunately, arteries, as they go from our heart and go down to our feet, get smaller and smaller and smaller until they get to our toes, where they're really, really teeny tiny vessels. So we check to see how patient's circulation is, and if circulation is not good, we'll recommend vascular doctors who can look into things further and assess your vascular status. There's arterial Dopplers, venous Dopplers, things that we can check to see how things are going with that. But we're usually kind of the first line of defense, and we catch these things earlier than other people do. So we check the skin to the pulses, the temperature of the skin, people that have cramping when they're walking. If you walk into my office and say, I can make it a block or two, but oh man, after that my legs are killing me. These are what we call claudication symptoms, meaning that somewhere on the line, that blood flow is not getting down there very well, and it's causing you to have pain when you're walking. So all things that we get checked out first, and then send people out afterwards. Smoking causes a lot of circulation issues. I tell everybody the same spiel, don't smoke. If you smoke currently still, stop. If you don't want to stop, God bless you. Please stop. But at the end of the day, natural aging plus conditions that we have reduces circulation. When you add smoking to the mix, it exacerbates things like crazy, and you're just doing yourself a disservice. So I have diabetics who smoke, and I'm like, you are doubling and tripling down on your health and issues you might have down the line. But we check these things as well. When it comes to veins, patients have what we call venous stasis. So if your legs are very swollen, if during the daytime you get up, you're okay in the morning, by the time you go to sleep at night, oh man, I can't put my socks or my shoes on anymore. These are typically vein conditions. And unfortunately, arteries bring things down, veins bring things back up. If the veins don't bring things back up again, gravity holds it down to our feet, our ankles, and our legs. Over time, if the legs get more and more swollen, you can eventually have pockets of fluid that have nowhere else to go, and they start popping out through the legs. So we've had patients that have had what we call venous stasis ulcers, or have had to have their legs wrapped up in tight bandages. That's one of the reasons why. And again, we catch these things early, send patients to vascular doctors. Vascular doctors can decide if there's any kind of vein removal, vein stripping, vein ablation procedures they can do that can help those things. But oftentimes we're the first ones to catch that. Patient comes in and says, hey, my pant leg keeps getting wet. Why? And let me take a look. Well, you've got an open sore there, and we have to look at that and have that assessed by a vascular surgeon. So, diabetes. That's one of the big ones that we always talk about. Now, not every foot condition is bad just because you're diabetic. However, diabetics, things tend to be exacerbated earlier. So, every diabetic should be seeing a podiatrist at least once a year. Once a year is for your healthy, everyday, hey, I got diabetes, but I mean, my A1C is like 5 point something, I'm active. Great, good for you, keep it up. But you should still see the doctor once a year. As you get older and as the condition worsens, we increase the frequency. We have patients come in every 2 to 3 months, like for young clippings, and we reassess and see how they're doing every couple months or so. Studies have found over the years that just seeing a podiatrist once a year can greatly reduce the chance of you getting a foot ulceration or a foot wounds that could ultimately lead to an amputation. Now, a lot of people don't know this happens because, I mean, you've heard stories, but people don't always know firsthand. But even a callus in the bottom of the foot for a diabetic can eventually rub and turn into an open sore. An open sore can lead to infection that can lead to an amputation. People that have had first generation or second generation relatives that have experienced amputations, it's never a good thing, but I will say at least you know about it. Because a lot of my patients will come in and just think it's not going to happen to them. They're in disbelief. True story, last night, I'm on call at Baylor and Grapevine. I got a patient, 34 years old, who came in. He needed his fifth toe and the bone behind his fifth toe amputated. And he's 34 years old. So if you're sitting here yourself, oh, I'm in great shape and I'm double his age, sure, but it can happen to anybody. You know, negligence of care extends beyond how old you are. So, you know, he's a sad case and he'll need big road recovery, but at the end of the day, you should always get yourself checked out. He did not get checked in a timely manner. He decided to ignore it and it got worse. So, my point of bringing that up is diabetics in general should be seen at least annually, and as you get worse, as you get older, you're seen more frequently, okay? So what do for diabetics? We do our circulation tests, and we also do nerve testing. When it comes to nerve testing, there's a few different methods we use. One of them, if you see the picture here, is called a Sims-Weinstein. It's this needle-looking thing, but it's not a needle. It bends when it touches your skin. We touch different parts of patients' feet. We have them close their eyes. They tell us if they feel something. If they don't feel anything, they don't say anything at all. And we can kind of use that as a screener to determine how far their neuropathy has advanced. In addition to that, we do a tuning fork, touch different parts of the foot, test how patients respond to vibration and sensation. We also, of course, subjectively, patients tell us if they're feeling tingling, burning, numbness sensations. So the way I tell people is this: if you're feeling tingling, burning, especially nighttime to go to sleep, in your toes, it's one of the first symptoms of neuropathy. As it progresses, it goes towards your whole foot, and oftentimes it can even be in your fingers and your hands as well. But your feet are usually the first places to experience that, and nighttime is usually the time when people feel it the most. The reason why it's nighttime is when you're walking, your feet are being distracted. They're not prone to anything that you feel. When you're resting, everything calms down, and you tend to feel it. The same way if you have a mosquito bite, you scratch the hell out of it, it feels great, all you're doing is distracting it because it's going to come back in a few minutes, it's still there. Neuropathy is a similar condition. Unfortunately, it doesn't go away like a mosquito bite, but it is something that can be treated. But if you have symptoms, that get it checked out. Neurologists are places we've sent patients often. The problem with neurologists is that they do those. I don't know if anybody's ever had a nerve conduction test. They sit there and they zap your nerves like you're getting electrocuted, static electric shocks every 3 seconds. The problem is it's great. It'll tell you what nerves are lacking and where they're lacking. But then you ask your neurologist, what do we do? He's like, no, I don't know. I mean, this is what the test says. Like, and that's it. They send you home, they say, here's some gabapentin, have a great day. So, you know, there's still value to going to neurologists. However, my reason for bringing it up like that is there are no cures. So they're going to tell you all this beautiful stuff and give you a printout of all of your nerve conditions, but there's no real cure for it. Again, there are some vitamins, B12 complexes, alpha-lipoic acid. There's companies that make combination of vitamins that can help, that you don't have to take gabapentin for the rest of your life, but they won't cure it, unfortunately. So, nerve tests, I won't get into this too much, we talked a little bit about it, but basically diabetics, and however many there are in this room, even if there's one, it doesn't matter, reach one person, right, as they always say. But you're at low risk if you have normal sensation, if you're walking around fine, you feel everything. Neuropathy puts you at a mild risk. Add that with peripheral vascular disease, circulation changes, you're at a much higher risk. And the highest risk stratification of diabetics were ones with previous wounds or previous amputations. So if God forbid you've had an amputation in the past, it's one of the biggest indicators for a potential future amputation. So even if it was years ago or whatever else, it can still happen. I don't have the stat in front of me, but something about if you lose a leg, I mean, you are you're not going to make it past like 5 to 10 years of your life at that point, losing one leg. Losing both legs, you're not long for this world for more than a couple of years, unfortunately. So there is a big battle with diabetics to get treated early and get treated right away, as often as possible to make sure these things don't come around. Now, I kind of call us the gatekeepers for the feet. And the reason why is because there's been countless times in my career, and I mean, I've done this for about over 15 years already since residency, that my career, I've had patients come in and we discover things. Hey, I didn't know I had diabetes. Well, you might want to get checked out. It sounds like you might have the symptoms of it, or peripheral vascular disease. And we decide if anybody else has to go to somebody else. So before you go see a vascular surgeon, before you go see a diabetic specialist, or even your primary for certain things, come to us first for foot and ankle related conditions, and we make that decision for you. So, don't often go straight to the vascular guy, and if you have one already, it's fine, but we can make that decision if you need to go, okay? So, we'll start talking about some age-related conditions, right? Things that affect us as we get older. And I'll stress, a lot of these things that we'll talk about, not this one's pretty much for older people, but some of these conditions can affect young people too. I have patients come in and say, when I was 20 years old, I would never have had this condition. I'm like, well, you could have. I have 20-year-olds come in with pain in their feet, with plantar fasciitis, Achilles tendonitis. It's not strictly related to older patients. However, as we get older, unfortunately, not old, older, we are prone to more conditions. So, I always preface before I even start this, if you stay active and you keep moving, you're gonna be fine. Patients that are inactive, don't wanna move, I'm not doing that today. Over time, if you don't use it, you lose it. So keep yourself moving. This is a great community because people are active, they're moving around. Keep doing that. So I'm not singling anybody out from looking, so don't worry about that. I'm just saying in general, keep yourselves going. So, fat pad atrophy. Fat pad atrophy is something that people may not even know about or have never even heard about. Basically what happens is, as we get older, the good fat in our feet, the good stuff, there's actually good fat in our bodies, we lose that good fat. Two of the places we lose that good fat from the most are the ball of our foot and the heel. So I will treat patients, especially women, but especially postmenopausal, post-childbirth women will lose the fat earlier than others, earlier than men. We'll see them in the office and they'll say, hey, I feel like there's a knot or a sock or something's bunched up in my shoe, right around my second toe joint. Very, very common spot. What usually happens is you lost the fat that covers the bone and you're actually walking more on those bones. So as you do that, you get inflammation or swelling that occurs around that bone, and you're actually feeling that swelling surrounding that joint when you're walking. So people always say the same thing, there's a rock in my shoe, there's a sock punched up, that's the reason why. And every time we walk, believe it or not, our big toe stabilizes us, but our second toe is actually longer by design. The bone behind it is longer, and that pushes the second toe out longer, and we're actually pushing off of that joint when we walk. So when we have fat pad loss and we're pushing off that joint pretty hard, we tend to cause swelling, inflammation, and pain in that joint. And over time, it gets worse, and we get more and more pain, and we have to see a podiatrist because we do certain things for it. Now, there are things we can do that are non-surgical. Not everybody has to wind up on the OR table being cut open. Inserts and shoes are very helpful, but I would stress people don't go to your pharmacy and buy Dr. Scholl's. They're not good. All they are just little paddings, and they don't do much to support any part of your body. Rule of thumb is if you have an orthotic and if you could bend in and out the arch, it's not an orthotic at that point. You might as well cut a piece of this rug out and stick it in your shoe, it's the same thing. An arch support has to be rigid. It can be soft on top, but it has to be rigid and not collapse down when you press on it. So, things that can help are orthotics. You put a good pair of inserts in, it takes pressure off the ball of your foot, you walk better, and you take less pressure off of that spot where it's hurting from. But just know there really is no cure for that either. Today's day and age, we actually do have fat replacement injections. So women who come in and want to wear high heels or want to wear wedges, you can actually inject fat into the foot over there nowadays. It's not cheap, it's several $1,000s, and you're off your feet for a few weeks while it heals, but you can actually permanently put fat back in those pads. There's companies that come to my office all the time that want me to take workshops on this. I haven't done it yet, but there's people that do this out there right now that inject fat into the foot. So there are options, but traditionally speaking, inserts and shoes and better shoe care would alleviate that. Okay, so muscle tone loss. Believe it or not, as we get older, the foot shrinks. And the reason for that is muscles tighten up and they actually contract back. When they contract back, it causes the muscles a tendency to shrink up and causes our foot to retract too. A couple different things can happen. That's number one, but also our foot can widen and shorten too. When it widens, one of the reasons for that is because, and again, not to pick on women, but they're more prone to it, as we get to postmenopausal ages, these structures that once supported our arch don't support the arch as much anymore. So the foot tends to slat down and become flatter than it used to be. So I'll have patients come in and say, hey, I always had an arch,
I don't have an arch anymore. What the hell happens? Then part of the reason is the muscle that supports it is no longer supporting the arch. It starts to collapse down. It starts to cause pressure and pain. And these are things that can be alleviated with either corticosteroids or orthotic relief, things of that nature. But just know that as we get older, it does happen. So if you said, hey, I always wear a size 7, all of a sudden I'm a size 6 or 6.5, that's the reason why. The muscles contract and our foot actually shortens up a little bit as we get older. Okay? And by the way, smokers, that happens a lot faster than diabetics, so don't smoke. Okay. Midfoot arthritis. I bring this one up a lot because patients that are very active and do a lot of walking will tell me, hey, I go for a walk and on top of my foot it really kills. Every time I go for a long walk, it hurts, it's painful. The reason is, if you see that arrow there, we get spurs, bone spurs, on top of our feet, especially people with higher arches, and that gets exacerbated with age as well. So patients will come in and they'll say, hey, I tie my laces really tight on top, it really hurts in those spots. Usually it's caused by bone spurs on top of the middle of the foot. There are procedures you can do to shave those off, but that's not always the thing people want to do, but there are procedures to fix that. But just know, if you are somebody who experiences that, try not to tighten your laces too tight on top of the foot. If you want to, there's felt paddings you can buy that go under the tongue of the shoe that actually can decrease pressure to those areas and slow the progression down too. So there are things that can be done to treat that, but just understand, if you are getting pain on top of your foot, especially after walking, that's one of the reasons why. We usually will take x-rays, we'll see this on an x-ray and evaluate that and tell you what to do, but that's one of the first line defenses is don't tie laces tight and put something inside there that can actually cushion that. Okay? How am I doing on the speed, okay? A little better? A little more Texan. Okay. What's that? Get back to get faster? Oh, man, okay. I'm trying. I'll let me know. Shout it out. I appreciate it. I gotta have multiple people in the audience who would let me know. So on the topic of arthritis, one of the biggest areas of the foot that we see arthritic changes in is the big toe joint. And I don't actually mean the big toe itself. I say big toe joint because layman terms, people will say that when they come to my office, but it's actually the bone behind the big toe. So if you look at the picture here, if you can make it out on top there, you'll see a bad foot on top and a good foot on the bottom. Okay? What happens is we get bone spurs there as well, and that's probably the most common area, aside from heel spurs, which we'll talk about later, to get bone spur. What happens on top of that big toe joint, where our toe actually bends on the foot, people get spurs, and that's an arthritic condition, and the joint actually narrows. So every time that big joint flexes upwards, it actually hits into itself. So patients will often say, I can't bend my big toe up, it hurts when I bend my big toe, it's stiff, it's painful. That's one of the reasons why. As the toe flexes up, it hits that spur, and it can't go past that point. Unfortunately, there are no cures for it other than surgical. However, we have to see what kind of surgery you need. Some people, unfortunately, when they get to that stage, if it's really bad arthritis, you actually have to fuse the joint, which is bring the bones together, put hardware inside, and it never bends again. The problem with that is it may not fuse properly, there's long-term conditions and ramifications of that, but essentially you're looking at a condition where you have to fuse the joints together, or else you'll never be able to walk pain-free again. So there are things to do about that. If it's as simple as a spur, yeah, it's better. If it's as simple as just a spur, that can be shaved off. So this picture indicates somebody just had it shaved off, and that's what you can do as well. So a couple weeks ago I had somebody in his mid-50s come to my office, and he keeps getting hurt when he plays golf, and we shaved it off. A couple weeks later, he's back to the golf course and he's fine. Maybe in the future it might come back, or it might get worse, but at least for the time being, there's ways to improve your conditions. But just know that arthritis does affect the foot. There are 26 bones in our feet. Between each bone is a joint. Each one of those joints can get arthritic. So people say, hey, my knees are arthritic, my hips are arthritic. I didn't know my feet can be arthritic, but they can. And you get arthritis in any part of the foot as well, which can be treated. So just know that too. Don't sit there and say, well, it's old age, there's nothing you can do about it. That's not true. There are things you can do about it. Right? But I bring this up because it's a common area. People often don't address it until it's too late. And by then already the joint is obliterated, and there's a lot less options for us. So if you're somebody who's walking and it really hurts that big toe joint, come get it checked out. Okay? All right. So this lovely foot here, I know, people always love this. We'll talk about bunions and we'll talk about hammer toes as well. But the reason I bring this up is because when people have bunions and hammer toes, what happens is these toes start to flex upwards, and eventually they stay rigid. They don't flex back. Eventually the bunions, or where the big toes are, pushes those toes upwards. So this is also an arthritic condition, but the challenge with this is, as we get older and the skin gets thinner, when we rub those toes on our shoes, we can rub open sores.
So this particular picture, not my patient, just a stock photo, but this person had where it rubbed the second toe joint open and has an open sore. And those could lead to amputations of toes. So the reason I bring it up also is because everybody in this room is young enough. Yes, you're all young enough. You could still do procedures to fix these things if you needed to. We all reach a certain point where we can't anymore, and our primary doctors wouldn't even allow it to be the case. But if there's ever a driving force to fix something, it's one of these things where the toes sticking up in the air, eventually it's going to rub on shoes, and it's going to irritate it. Once you reach a certain age or condition, our textbooks will actually tell us just to amputate the toe, because it's a lot less recovery time than actually do a procedure where you cut the bone and make it straight again. But these are very common things that we see, unfortunately, out there. So somebody might be sitting in this room saying, oh, I have a toe that sticks up. Okay, get it checked out, see how it is. And if you don't know what your feet might look like, if you remember your parents' feet, we unfortunately inherit our parents' feet. A lot of this is genetic. It gets passed down through the generations. So you can thank mom, you can thank grandma, you can thank old Aunt Millie, whoever it was, for these conditions. Yes, they get exacerbated by high heels and by shoes that are tight fitting, but they don't start because of that. They usually start because of genetics. So it's not your fault you wore high heels and worked in business your whole life. It made it worse, but it's somebody in your family that gave it to you originally. Okay. So let's talk a little bit about bunions. And one of the reasons I like to talk about bunions is because one of my favorite things is when a patient comes in the office, one came in this morning actually too, they think that bunions are growths of bone. So the big thing is people think that there's a bump on the side of the foot and it just grew overnight. A big bump came out of nowhere. What actually happens is, if you see the picture here, the one on the left side of the screen, that's a straight toe. If you look at the one on the right side, the bone that leads up to the toe, which is our metatarsal, actually starts to drift outwards. When it drifts outwards, it creates that pressure point or that bump, and then our big toe starts to go inwards. So bunions are not extra growth. They're actually bones that are off of their ankle. They're not where they're supposed to be. So our goal of surgery, or whatever we might do, is to correct that alignment, is to put that back in place. Now, not everybody needs surgery. You can walk around with a bunion your whole life and never have an issue. If you're somebody who has pain when you walk, you can't put a shoe on, it's too tight, it's too painful, bunion surgery is worth exploring. In the interim, there are conservative options: wider shoe gear, inserts in shoes, even steroid injections can calm it down. But unfortunately, the only way to fix this is to do bunion surgery. And I bring it up because people come in here with these pads, these straps they buy online, and they say, hey, can I pull the bunion over? You can. The problem is you can wear that every day for 6 months. Never take it off. Your toe is perfectly straight, it's beautiful. I don't know how you pull it off wearing it for 6 months straight, but let's say hypothetically. As soon as you take it off, it's gonna look great for 5 minutes, and it's all gonna go back down. You can't correct tendons and you can't correct ligaments. Only surgically can you do that. But I bring it up because I tell people, look, you don't have to have surgery. Not everybody is a surgical candidate for bunion surgery. If it's something that bothers you, it's hard to walk, it's difficult, it's causing pain, great. If it's strictly cosmetic, you don't do it. If you've never had pain before, and then you do surgery, you can introduce pain and make things worse. So we, at this point of our stage of insurance society, if you come in and tell the doctor I don't have pain, we technically can't even book a surgery for bunions. It's strictly not cosmetic. Are there guys who do it? Yeah, I know some of the guys that do it on anybody, but I tell patients of mine, if it doesn't hurt you, if it ain't broke, don't fix it. You can live the rest of your life with it and never have a problem, okay? So, we talk about surgical correction. I put this up yesterday. This is a patient I did a couple weeks ago, only to illustrate some of the surgeries we do. Oh, yeah. Thank you. I bring this up just to illustrate some procedures we do nowadays. Procedures have changed over the years. I've had people come in and tell me that they did bunion surgery back in the 80s and 90s, and a lot of times it was just shaving off a bump, and that was it. The issue is if you just shave off that bump, you're not going to be happy with it in the future. It's going to come back. No matter how old you are, it's going to return. So what we do nowadays is we do surgeries where we cut the bone, move it over, and put hardware inside. So this particular case was done through minimal incision surgery. One of the big things we do now is make a small cut, and through that small cut, we do the whole procedure. Now, you may not have to have this done. This is pretty extensive, and she's somebody who's only in her late 40s, so she has a long time to go. We don't want it coming back. But there are multiple ways to do procedures nowadays. But just know, majority of procedures require you to be off your feet for at least 4 to 6 weeks. And not entirely off, you have to wear a special walking boot, but you're not doing activities, you're essentially not walking normal for at least 4 to 6 weeks. Some people it's a little bit longer, depending on osteoporosis or bone quality, it could be longer than that to heal. But a majority of people, you're talking about 4 to 6 weeks at least. But I also put this on here to illustrate again, if you look at her pre-op versus her post-op x-rays, you can see the angle that changes there. Our goal is to realign that toe joint. We want it straighter. So in the first one, her toe's knocking over into the second toe.
on the next one, where the post-op is straightened out. And that's one of our goals of surgery, is to bring the toe straighter, but also to realign the joint so we don't have any pain and pressure on the side of the foot. Now, this will take a year to consolidate fully. She could walk sooner than that. She's already walking in a boot, she'll be fine. But bone will eventually fill all those gaps in, and will eventually go around the plate to solidify it, and that can take up to a year. So you can still do whatever you have to do, but running activity, we usually don't have patients do for a couple months. Weight training activity, maybe a little bit longer, depending on how much weight you use. But bunion surgery is not the simple thing people think it is. And I bring that up just to illustrate that, because we think of back in the day just shaving off a bump. It's much more than that today. Okay. Hammer toes. So bring this one up with the lady that we saw before, the stock photo that had the one on top of the toe. What happens in a hammer toe is this. It's not that your toe all of a sudden started changing shapes or positions, but in the toe joints themselves, there's little tiny ligaments. Their jobs are actually to keep our toes aligned straight. As we get older, again, not old, as we get older, the bigger muscles overpower those small ligaments. So those teeny tiny ligaments that were in charge of keeping the toes straight can't do it anymore. So over time, the toes start to contract backwards. Now, at first, it's reducible, meaning if you pull your toe, you can straighten it out. As time goes on, you can no longer reduce them. If you pull your toe, it's pretty rigid. So rigidity occurs as we get older, and that's something that unfortunately cannot be fixed other than surgery again. You can put pads over your toes. We can talk about inserts, wider shoes, wide toe box shoes. However, you can't fix it unless you actually surgically go in there. What we do is we actually cut a piece of bone out of the toe. So, it sounds lovely, but I tell people the honest truth. That's what surgery is. You go in there, you cut a piece of bone, you straighten the toe, and sometimes you put a pin inside the toe to hold it straight. Sometimes you don't need it, sometimes you do. But essentially what you're looking at here is as we get older, they become more rigid, more painful. And the problem people have is mostly on top of the toes. Shoe gear rubs in the toes, everything you wear rubs in the toes. When you walk, when you do exercise, you feel the pressure from that rubbing. You can reduce the pressure by wearing pads. There's certain things you can put on top of them, form pads, tube foam. Those things can slip over the toe, but unfortunately they can't change the process itself. Once it starts, it keeps going. So, we talk about shoes for a second. People often ask, are there any specific types of shoes I can do to fix that? Well, while no shoe typically fixes it, what happens is there are shoes out there that can help you. So I bring this up because diabetics will qualify under Medicare once a year for diabetic shoes. Diabetic shoes are more restrictive than they used to be. However, most diabetics with any kind of conditions can qualify for shoes. Typically, as we get older, you want the shoe to be a bit more rigid. Rigidity of the shoe matters because when you're younger and you've got a more flexible shoe for running purposes or whatever else, that's fine. You can feel every bend, every move, every twist. As we get older, a more solid shoe on the bottom doesn't allow our joints to bend as much. So if you think about I don't know how many people here are hikers, but hiking shoes. Hiking shoes are a lot more stiff and rigid on the bottom. So when you walk on a rock or you're rock scrambling, you're not feeling that bend in your foot. It's actually more like I jokingly it's like a horse hoof. A horse hoof just kind of clamps down on the floor. That's what you're kind of doing when you're walking. You're not allowing your joints to bend too much. So when people ask about certain shoes for all these conditions, something that's more rigid is preferable. And also thinking about adding an orthotic inside to the mix as well. Orthotics can be over the counter, orthotics can be customized, it depends on what you need. But like I said before, don't go with Dr. Scholl's or some over-the-counter variety that's gonna not do anything for you. All right. I'll talk about this one next because I like toenail fungus. I don't know any podiatrist that doesn't like it. It's part of what we do. So I talk about first that there are studies that suggest that almost half of the people over 50 years old have some sort of version of fungus. And when I say some kind of version, it's because I treat people in the office that don't necessarily have fungus, but it looks like fungus. So what happens is this. People come to the office, the nails are thick, they're yellow, they're discolored, and the automatic assumption is fungus. However, if you've ever been an athlete during your lifetime, if you ever dropped something on your foot, it can also cause your nails to disrupt the pattern they grow in, which can look funky. So oftentimes I'll have people say, hey, 50 years ago I used to be a marathon runner, all my nails used to fall off when I ran. Yeah, that could be a reason why your nails are now thicker, more discolored, is because of trauma. Trauma can do what fungus does, but you can't cure it. So I bring that up because people often be convinced it's fungus, but it won't necessarily be fungus. One of the ways we check for that is we actually take nails, take a piece of it, send it to the laboratory, and have the pathologist look under a microscope and tell us if it's fungal or not. Based on that, we'll talk about treatments later, but I bring that up because it's not always fungus. I will tell women here especially, pedicure places are hotbeds for fungal infections. Be careful. If you go get pedicures often, I don't care how clean you think it is, it's not as clean as you think it is. Those plastic liners they put in the basins, they're not impermeable, things get through them. And also when they're using polishes on you, they're dipping that brush right back in the jar and using it on the next person. So if you got hot pink and Tracy behind you gets hot pink, you're all getting the fungal infection that the original person had. So be very careful of these nail salons because they are hotbeds for fungal nails. But also, the reason I bring the age up as well is because as we get older, circulation changes, as we talked about before. When we have reduced circulation to our feet, what happens is nutrients that help keep our nails healthy and clean are not getting down to the toes as much as they used to. Because of that reason, the nails will naturally thicken and naturally get more discolored. Patients always come in that are older and say, hey, can we treat this fungus? And yeah, it might still be fungus, we have to look at it, but just know that it's not always fungus. Again, half the people over 65 are having conditions like this, then it's not always because of fungus. So, let's say it is fungus. Let's say you're sitting there saying, my nails are thick, they're grotesque, and I'd love to fix them because every time I go on vacation, I dig my toes into the sand and I don't let anybody look at them. That's a common thing, by the way. There are ways to treat this. Number one are topical medications. Topical medications are easy. You just slap some cream or polish on top of the nail and you go about your business. The problem is that you have to use them for a long time and they're not very efficient. So the best topicals out there, studies show 30 to 40% effective rates. So if you think about that, 3 out of 4 people out of 10 are going to get better in about a year or two. And when I say a year or two, it's literally because each nail cycle could take up to 9 months to a year to grow out, and sometimes you have to use it for up to 2 nail cycles. So I don't know how many people here are diligent, but not many people I know are that diligent on using it for a year to 2. They might use it for 3 weeks, 3 months, maybe 6 months, but after a while get disheartened if they don't see any results. We become an instant gratification society. If you order Amazon, you wonder why it wasn't there yesterday before you ordered it. So results take a long time, and topicals take the longest to see results, unfortunately. But they're safe, they don't do anything harmful, and you can certainly start with that first too. The next one up is oral medication. Oral medication has been around since the 90s. If anybody remembers, some people oddly do sometimes, but there used to be commercials on TV where these little gremlin-looking structures would dig under people's toenails. And the drug they were selling was called Lamisil. And Lamisil came out probably in the early mid-90s. It's still the only real, true treatment for fungal toenails. There's no money in it for pharmaceuticals, so they're not making anything new. So it's been around for a while. Oral medication is a lot different. It's more like 70 to 80% effective, and you only have to take 1 pill a day for 3 months. So much easier than topical medications. However, why would some people not want to take it? Well, unfortunately, it can affect your liver. When every medicine we take gets filtered out through our kidneys or through our liver. While some organ systems can take a punch, some organ systems can't. And the liver, over time, if you damage it enough, yes, there's regeneration, but it can only regenerate so much. So a lot of primary doctors do not want patients taking oral medication because of the effect on the liver. If you do opt to take it, or your primary doctor says, yeah, go for it, you have to do blood work before you take it, and blood work while you're taking it to make sure there's been no effect on your liver. If there's somebody who drinks alcohol, 1 drink a day is not a big deal, but if you're somebody and you know this about yourself that you're going to do more than that, then if you use this on top of that, you really have a strong chance of hurting your liver, and it's not worth it. However, the effective rate is double what you take in a topical. So some patients are young, they're healthy, don't have medications, don't have any liver conditions, hepatitis, fatty liver, any cirrhosis, can do it, but you have to get clearance from your primary doctor first. The third one is laser therapy. Laser therapy, I have in my office, I love laser therapy, and we'll talk about the bad side of it because there's always a bad side. But the good part of it is very effective. It's 80 to 90% effective. It's 1 treatment a month for about 3 to 4 months, and you come back in later and you see how things are progressing. The downside is not covered by insurance. Insurance decided that this was totally cosmetic, and that they don't care if your nails are thick and discolored or disgusting and make you feel bad. They don't care. So I make a joke in my office. I often say Medicare should be called Medi Don't Care because they don't really care about what we do and how we get taken care of, unfortunately. But they don't cover it. So you're looking at several $100s for toenail treatments, and people do it, but it's entirely up to how you feel. Because it's cosmetic, you don't have to do it. If you live the rest of your life with nails that are thick or discolored, you're going to be okay. It's just about how you feel. I will say that people always ask a question too. The fungus in a toenail will not go into your body and cause a systemic effect. There is that really low chance it could, but it's very, very, very rare and I would never tell you it's a possibility of happening. But in general, it does not affect the whole body. So it can sit there forever in your toenail and never do anything bad to you. It's just in your toenail. So a lot of it is our own feelings about it and how we don't like it. That's okay too. It's worth treating if it affects you. But it's one of the reasons why insurances don't cover these procedures is because they don't care. It's your toenails, it's all about the look, and it's up to how you feel, okay? So, and we'll kind of dive into this before, but basically, you can come in and have them clipped down and filed. I use a Dremel in my office, like a Dremel anybody may have used in their garage back in the day. But the Dremel will file down these nails, you make them look better, more presentable, and feel better, and that's something we do too. So if you didn't want to do any treatments for it and you want to live with it, you can do things to make it look better and make yourself feel better by just having nails clipped, filed down, and if you want to do something more advanced, you can take a sample of the nail, check if it's fungal, and decide if you want to do any kind of treatments for it. Okay? All right. Plantar fasciitis. I like talking about this one because there's so many misconceptions about plantar fasciitis out there, and almost everybody in the room has always had somebody who dealt with this. Unlike other conditions we may have mentioned so far that haven't affected people as much, you always find somebody who knows somebody who has plantar fasciitis. So what is it? Well, heel pain. Now, what I mean by just heel pain? Most people who have plantar fasciitis, the common presentation is getting up in the morning, putting your foot down, your heel hurts in the morning. Now, not just the morning, but when you're sitting down for lunch, having dinner, you're driving a car for a while, you get up after you've been sitting down for a while, that foot hits the floor, it becomes painful. What happens is this: it's not necessarily the heel spur. And there are heel spurs, and we find those on x-ray. However, back in the day, we used to take patients to the operating room and shave off heel spurs, and people don't get better. So what we found over the years is, while you might have a spur, it's not necessarily consequential. The reason I mention this is because most people come to my office that think they have plantar fasciitis will immediately say, I have a spur, or my buddy at work told me I have a spur. And I always answer with, well, your buddy must have great x-ray vision, because I don't know how the hell they know that. But at the same time, it's not just the spur that causes that. So let's rewind a little bit. What happens is this: the muscle, the plantar fascial muscle itself, where you see that kind of white band on the bottom, it inserts into the heel. Every muscle in our body comes out of bone somewhere and goes into bone somewhere else. It comes out of the heel and goes into the ball of our foot essentially. Somewhere in the middle of the foot, it splits off into a few branches, but we won't dive into the anatomy too much. But essentially, the area where it inserts into the heel is prone to inflammation. So if you're walking too much, if you're not wearing proper shoe gear, maybe you went on a trip to Europe and you walk 20,000 steps a day, and that's 15,000 more steps than you used to walking in a day, you can cause that muscle to inflame and get swollen. Now, this is a muscle that likes to be very loose. When you walk, it flows with your foot. If you step on a rock, it goes over the contour of the rock with your foot. When this happens, it doesn't do that anymore. Instead of being loose, it cranks up and tightens up. So when you put your foot down in the morning, people are like, oh my God, it's like stepping on a piece of glass. As you walk, it actually relieves it a little bit. People feel a little bit better. There's a little less pain in the area. But then as soon as you rest, that inflammation comes right back again. So that's one of the telltale signs of plantar fasciitis, is heel pain. It keeps coming back and doesn't go away. Now, the ways we usually treat that, we'll talk about a few things today, but what I'll always tell people is surgery is rare, very rare. I finished residency about 15 years ago. 13, 14 years ago, whatever it was, I can't count anymore. We rarely ever took patients in for surgery. So heel spur surgery, forget that. But nowadays, if we ever have to do surgery, it involves actually cutting the plantar fascial muscle and making it longer. We extend the muscle. But I could say in my years of practice after residency, there's only been a handful of people I've ever had to take in for surgery for that. There's always a way out of this mess that does not involve surgery. However, there are some people that do get to that point. The most important thing is you want to diagnose it correctly, get an x-ray to make sure you don't have a stress fracture of your heel, which is a rare stress fracture to have, but people do get stress fractures of their heel. I'm looking at someone over there who I talked to beforehand, a nurse. But in general, it's a rare fracture to have, but you do want to check to see if you have that first. So diagnosis is key. Next thing is this. Believe it or not, the number one treatment for plantar fasciitis is stretching exercises. The more you stretch, the more you move that muscle, the more inflammation you break up. The problem is stretching by itself takes a long time. So if you stretch the hell out of it, multiple times a day, multiple times a week, multiple weeks, it still takes a long time for that stuff to get rid of it, for it to actually loosen up permanently. So we talk about anti-inflammatory medications like Voltaren gel, oral anti-inflammatories like meloxicam. These are all helpful. Orthotics can help, but I always stress to patients, orthotics are not a cure. If you walk into a podiatrist's office and he says to you, I got plantar fasciitis, let me just make you some $500 orthotics. Great, I mean, they're fantastic to have, but they will not cure your pain. So to spend that kind of money, it's fine for long-term benefit, however, for the short term, it does not cure you. Plantar fasciitis will not be cured by orthotics. It can help, but it won't cure it. Unfortunately, the best ways to get better are corticosteroids. So people are afraid of cortisone shots, and I understand why. And we'll talk about alternatives, because not everything is cortisone nowadays either. But cortisone shots are sort of our tried and true way to approach it. When you take an oral anti-inflammatory, that anti-inflammatory has to go through your whole body. It doesn't know where to go. It's going everywhere. It's going through your bloodstream to your arms, to your head, to your feet. It doesn't know. When you do a steroid shot, it goes exactly where you need it to go. So if anybody here has ever had a steroid shot in their knee or their hip or their back, it's because they're targeting the area of inflammation directly dead on. And the same thing happens with our heels as well. We give people a heel injection, up to 3 actually, so hopefully 1 works, but sometimes it doesn't, 2 or 3. After 2 or 3, the rule of thumb is stop doing it. If 2 or 3 aren't working, 4, 5, and 6 are not going to work either. So 2 or 3 is our magic number. At that point, I don't know if you're familiar with cortisone, but it can be dangerous after a while too. If you give too much cortisone into a joint, you can erode the joint, you can make it arthritic if it wasn't already, you can make the arthritis worse, or if it's a tendon or muscle, you can actually weaken a tendon or muscle and cause it to tear. Does it happen after a couple shots? No. If it happens after 5 or 6, yeah, it could. So you definitely want to make sure you don't have too many cortisone shots. I've seen countless patients in my career that have gone to a podiatrist and had like 10 shots. And I start to say, who the hell was doing that to you? But also, why did you stay that long for 10 shots? But it's a crazy thing, but that's what they're programmed to do. They just keep giving a shot and they think eventually it's gonna work. But unfortunately, not everybody works for it. The vast majority of people, it does. So cortisone shots are kind of our first line of defense. Now, if that doesn't work, we have things called shockwave therapy. Shockwave therapy is depicted in this picture here. Shockwave is, I kind of tell people, it's like, if you think of athletes, they use these big massage guns. Have you ever seen those big hydraulic-looking massage guns? It hits into the heel about 3,000 times in a few minutes. What that does, it stimulates blood flow to the area, but it also stimulates the body into thinking it's being hurt. So part of what happens in chronic pain versus acute pain is in chronic pain is pain your body shuts off at that point. When you injure yourself, an acute reaction is our body sends inflammatory markers, it sends things to help the body heal. After a while, if it's not healing, the body says, well, what's the point of wasting resources? It's not getting better. We're going to shut this off. So chronic pain is basically our body saying, well, we're going to deal with this and we're just not going to do anything at all. What we're trying to do is we're trying to trigger the body into thinking it's an acute inflammation that it just happened to you. So you're kind of trying to simulate an injury so the body will actually send its own inflammatory markers down to the heel and help it get better. Usually it's about 3 to 4 treatments of this, and people do get better as well, but it's an out-of-pocket expense. Medicare used to cover it, then when they decided not to, which was fantastic. Despite the fact that there's research out there showing that it works, Medicare decided not to cover it. Laser therapy also works, so when we talk about laser for toenails, laser can also be used on muscles and tendons, and what it does is decrease inflammation. So all of our treatments are geared towards decreasing inflammation around the heel. Anything we could do to decrease the swelling and decrease the process that's happening around the muscle itself. Other things we do today are also PRP and amniotic injections. Amniotic injections are also referred to as stem cell injections. That can also be done, if people have heard about it, people do that in the back, in the hip, in the knees, and different joints as well. What they do is they actually take placental tissue or umbilical cord from a pregnancy, from a birth. And I always preface it's from an actual live birth, it's not from any kind of aborted situation. So it's done from actual full C-sections, where they'll take the stem cells from the amniotic fluid and actually clean it and turn it into stem cells that they can use to inject that. And again, it's done for every type of condition too. We have people that do that for orthopedics, for backs and hips and knees. And what you're doing is you're repairing tissue with that. So unlike cortisone, which doesn't do anything to repair, just decrease inflammation, amniotic injections or stem cell injections actually help repair tissue, they regenerate tissue. They take stem cells that don't know what to be, they introduce them to an area, and it actually helps things heal that way. So that's gaining a lot of traction lately. It's become really big in the industry and medicine in general, but unfortunately it's not covered by insurance. So wherever you go, and if you do that, it's all out of pocket, unfortunately. But it does work too, and those all are alternatives to these other corticosteroid injections too. Okay? Yes?
Does it last longer than the cortisone?
Yeah, so technically it's supposed to. I mean, cortisone can always fade away, and when I talk to people about cortisone, the big thing I hear is it just a Band-Aid? Is it just a way to cover it up? Yes and no. I mean, cortisone can take away inflammation and make you feel better. And if you change whatever got you into that situation, it can never come back again. So for instance, plantar fasciitis, what we're talking about right now. If you had heel pain, you do a cortisone shot, and you feel amazing, there is no time limit for that to expire. So people say, 3 months from now it's going to come back. Not necessarily. If you don't change something though, it can come back. So if you keep stretching, if you wear inserts, which are, again, not curative, but good for long term, you can change the biomechanics of the foot and actually never get this back again. So plantar fasciitis can be cured with a cortisone shot, provided you do the right things that get you out of it. If you relapse back, if you don't stretch, if you don't wear proper shoe gear, you keep getting it over and over again, and eventually the efficacy of the cortisone shot decreases over time. Whereas these injections don't. They are more curative. But they're expensive too. They're several $100s depending where you go, even thousands of dollars depending on some industries, and you have to get multiple injections. So usually for the heel, I just gave a gentleman one a few days ago. He had one injection, he'll come back a month later, and if he's not getting better after the second one, he would do a third one 2 weeks after that. So it can be expensive because you have to do multiple shots, but it is more long-term because you're actually restoring tissue, you're regenerating tissue. So on that level, yes, it is better, but it's more expensive. So, not everybody can afford it, unfortunately, and it's, when it becomes more commonplace, it probably will get cheaper, and if one day insurances do cover it, which would be great if they did, then it'll be much more of a different situation. But yes, if you had to pick one of the two if you could afford it, this would be the way to go, for sure. It would just take longer to get better, I warn you that, because it does take longer to have an effect. Cortisone is like an immediate effect, within a day or two. So people want to feel better, yesterday, right? So that is a faster way to do it, but there are ways to do it that are not corticosteroids.
Could you do both?
You could. I mean, I wouldn't necessarily think about doing both at the same time, just because they're both so markedly different. But you could. I've had patients. What I would usually do is give one of these growth factor injections, and then have them back a week or two later do like a shockwave therapy or laser therapy. So you can use things in combination, just get the flow over the hump. But I wouldn't do cortisone with that one together. No, I would try not to. Okay. Now, the next type of pain associated with that is Achilles tendonitis. Now, for those that don't know, your Achilles tendon is part of your calf muscle. So your calf muscle comes down to where your heel is and it becomes your Achilles. So the comparison I used to use in the office is a wine glass. Think of your calf muscle as the top of the wine glass and your Achilles as the stem of the wine glass. So they're all connected. And the reason why it's important is because when we stretch, we'll talk about it later, you want to stretch your calves to get your Achilles better. So how does this differentiate from plantar fasciitis? Well, instead of the bottom of the heel, this is the back of the heel. So people that wake up in the mornings and are bending or moving and they feel pain more in the back of the heel, it's usually your Achilles. And like the plantar fascia muscle, it's all about the insertion of the muscle. So the Achilles inserts at the back of the heel and it gets inflamed or swollen, and that causes patients to have pain. What you're looking at here is kind of about the area where it is, where most people get it, but usually it's a little bit lower in the picture where the action goes into the bone. So what happens is it hurts during activities, it hurts when you get up in the mornings, and it hurts after you've been resting, similar to plantar fasciitis. The difference I tell people about is this: the Achilles does not have good circulation to the area, so it takes longer to heal. If God forbid you ever rupture your tendon or tear your Achilles, you're much more likely to have surgery there than you are other muscles, because the likelihood of it healing by itself is a lot lower than other muscles healing. And this happens to everybody. This happens to our weekend warriors, it happens to our world-class athletes. It doesn't make a difference who you are. You can be prone to an Achilles tendon tear or Achilles tendon rupture. Most commonly, we see the guy who works at a desk 9 to 5, doesn't do anything, then Saturday wants to go play pickup basketball, goes up for a jump shot, and tears their Achilles. But it can happen to anybody, so be careful even on the golf course. I've had patients that have torqued too much and torn their Achilles, so be very careful. Stretch, get yourself up in the mornings, move a little bit before you start games, you'll be a lot better. So, the way we look at this first, we take x-rays to see. Sometimes people have heel spurs in the back of the heel. Unlike heel spurs at the bottom, the heel spurs in the back can affect people in different ways. There are some people that have what we call a bump in the back of the heel. The tendon has trouble going over that bump, and sometimes those require surgical procedures to remove those. If there's ever a spur removed in the heel, it's most likely in the back of the heel, not the bottom of the heel. Those are brutal surgeries. You have to cut the Achilles, move it out of the way, cut the bone, reattach the muscle, and you treat that like an Achilles tendon tear, but we won't get into the surgery right now. But just know that there are times when people get heel spurs at the back of the heel, and those do have to be treated with surgical procedures. Now, in general, one of the big factors, the big differences between plantar fasciitis and Achilles tendonitis is the Achilles does not like cortisone. Cortisone is never, ever, ever, ever done. One of the stories I bring up, just being from New York, is back after 9/11, there were anthrax scares all over the place. Remember this? People were shipping powder, white powders everywhere, and everybody was worried about getting anthrax poisoning. So what happened was they started prescribing ciprofloxacin like crazy to themselves or other people, because apparently that was a remedy of that. What they're finding was that ciprofloxacin, taken too long, can cause a rupture of your Achilles tendon. Now, while it's not cortisone, the issue is that people that take Cipro for too long, I always bring this up, be very careful. Cipro is very dangerous for muscles and tendons and can cause a muscle tear. Just the same way cortisone can in the back of the heel as well. The Achilles is not like these things. The Achilles is like the fluoroquinolone, ciprofloxacin, Cipro, and then the Achilles is not like cortisone either. It's very prone to tendon tears and tendon ruptures. So, when we talk about getting the Achilles better, the first line of defense is stretching again. If you stretch every day, if you move that muscle, move that tendon, you can actually break up the inflammation and make yourself feel better. Anti-inflammatories are fine. I love Voltaren. Voltaren is a great go-to. Voltaren, you just rub over the area, and that can decrease inflammation too. And if things aren't getting better, then you think about things like laser therapy, even sometimes mobilization, where you put people in a walking boot for a while, or even physical therapy. So Achilles tendonitis, just like plantar fasciitis, can cause debilitation of walking, but the difference is you can't get cortisone shots. So that's off the table. So I get patients that always ask me, and I put that out there to all my audiences, that the Achilles and cortisone do not mix well. If you walk into somebody's office and they offer you one, leave. Because there are still some guys that will do it, but you should not do it. It's very dangerous. Okay. Now, plantar warts, I bring this up because people ask, but honestly, you don't see it affect the older crowd as much. Now, the very old, yes, but not so much the regular older crowd. The reason is because warts are a virus, and warts live in the skin. The people that are more prone to the viruses are people that are more immunocompromised. So you see kids get it a lot, and you see older adults get it a lot because their body doesn't fight it off. But it's a virus that lives under the skin, and it causes these types of clusters of callus that form over the surface. And what we do is we shave those down, we expose the warts, we freeze them, we burn them, there's different things we do, but they're calluses that don't go away basically. Calluses in general, when you shave them down, can be caused by pressure points, but these are ones that don't go away. So I bring up warts because we all, I'm sure many of this room have grandkids. If you go visit your grandkids, make sure they don't have warts. If they do, don't share their showers or walk on the same floors as them, or wear something on your feet first, because you can't get them from your grandkids, which is the most common group of people to get these are kids, okay? Now, neuromas. I bring these up too because patients often ask me about neuromas. Neuromas are basically inflammation of nerves. So, in our feet, we've got nerves everywhere, but specifically when the areas between our toes, there's nerves that go from the top that dip down to the bottom. Those nerves can be under a lot of stress, either from activity, from walking too much, from rubbing in shoes, whatever it is. That can cause inflammation of nerves. Over time, that inflammation gets so bad that it actually stays inflamed and stays swollen. And we basically call these like little tumors around our nerves. And that's what can happen over time. So the telltale sign of that is when you're walking, if you get a lot of tingling and burning between your toes, and exceptional amounts of pain between the toes, specifically the second and third toes, that's the most common, that's usually a place to look for a neuroma. Neuromas can be cured without surgery. Corticosteroids can reduce the size and make it better. Some people eventually need surgery, but the only thing you would do first is always run an MRI to make sure you don't actually have a neuroma. A lot of times it can be different reasons causing the pain. You remember before we talked about fat pad atrophy. Patients have the same symptoms of that, but it doesn't go away, and we think we're treating that, but ultimately they might even have a neuroma. So things like that can be pretty deleterious to our walking. But I bring these up because people ask me about neuromas sometimes and don't often know what it is, but it's basically just inflammation or swelling of nerve ending. And that can be cured without surgery, but unfortunately for some people they ultimately require surgery. And I think one of the last things we'll talk about here is athlete's foot. Athlete's foot affects everybody too. Young and old, doesn't matter. But basically, if you're getting itchy spots on your feet, if you're getting these little vesicles that kind of cause little pus pockets in your feet, it could be athlete's foot. Hydrocortisone is a great way to calm it down, but ultimately using an antifungal, even over the counter to start with, is a great way to start. If it's not getting better, if it's not improving, then going to see your podiatrist and getting something more prescription strength is the key. If you have a recurrent situation in your life where you've had athlete's foot, I tell people all the time, take all of your shoes you wear once a week, whether they're athletic shoes or church shoes, wherever they are, spray the inside with Lysol. Just douse the hell out of Lysol. Now, don't put them on right away afterwards, because I've had people do that and then get mad at me about it and say that you made my socks get wet with Lysol. Let them dry overnight. What that does is it kills bacteria, kills fungus in the shoes, then we infect ourselves. So fungus, whether it's nail fungus or athlete's foot like this, loves to live in warm, dark areas, moisture. Our feet, our shoes are wonderful places for that. We get sweaty, it's dark, it's damp, and unfortunately fungus breeds in our shoes. So we often infect ourselves and we cause athlete's foot. So I tell people, spray your shoes down with Lysol. You don't have to buy fancy UV lights, you don't have to buy crazy gimmicky things. Lysol's all you need. Spray the inside, let it dry, and that's it. But a typical athlete's foot infection, especially between the toes, might take a while to go away. If you're not getting better with over-the-counter medications for a few weeks, then see a podiatrist. Because most people will get better with conventional methods, but some will need a little bit stronger medications. But I put that out there because somebody out there has had athlete's foot at some point, some people get it recurrently, and it becomes a real big nuisance. And one of the ways to prevent it is taking care of our shoes and cleaning them. Okay? So, I leave this part up to questions and answers.